morning. It's my pleasure to introduce Dr. Ana Fernandez Bustamante, who's currently an associate professor here at the University of Colorado. Ana earned her MD from the University of Valladolid and her PhD from the University of Madrid in Spain, where she also did her residency in anesthesiology. In 2004, Ana then moved to the United States and did fellowships in translational lung research and cardiothoracic anesthesiology at Johns Hopkins University. In 2008, she joined our faculty as a physician scientist and has since then been a very successful researcher within our department. She has over 40 peer-reviewed publications, was able to get the prestigious training grant from the Foundation for Anesthesia Education and Research, which allowed her to also obtain NIH funding. Ana just received 2 new grants, one from the NIH for a multi-center trial grant to study anesthesia care bundles to reduce postoperative pulmonary complications, and one from Merck to study sugammadex versus neostigmine for reversal of neuromuscular blockade at the end of kidney transplantation surgery in patients with severe kidney dysfunction.
Thank you, Dr. Gilliland, and everybody for coming here. I'm going to be talking about neuromuscular blockade reversal with sugammadex in patients with kidney dysfunction. And this is part of the study that has been recently funded by Merck. So the goals today are going to be recognize the importance of adequate neuromuscular blockade reversal, understand the benefits and challenges of using sugammadex for reversal in patients with kidney dysfunction, and introduce the coming study. You probably all know what inadequate reversal neuromuscular blockade means. It means that patients after tracheal extubation may have some residual neuromuscular blockade and weakness. And the incidence in the literature is going to vary widely depending on the muscle relaxant management they used, the reversal management they used, the monitoring, whether it's clinical observation or qualitative train of 4 or quantitative train of 4. Although the studies that will investigate the topic specifically will mostly use quantitative train of 4. Even then, depending on what accepted level of residual blockade is going to change the incidence of that residual blockade. As a brief summary, and you can find these many reviews on this topic, but this graph shows the more or less expected complications, clinical relevance of different train of 4 measurements that you can see in the literature. So if you go from a train of 4 of 0.9 or greater, which is accepted adequate muscular blockade reversal, versus a 0.7 or less, you're going to have patients that are more likely, increasingly at risk of swallowing discoordination, which puts them at risk of microaspiration or frank aspiration, progressively more hypoventilation, and respiratory failure and overall muscle weakness. So the way I think about this is we probably catch the peak of the iceberg. We only see the clinical cases of those patients that have very obvious poor residual or poor reversal of muscle blockade, and then do have symptoms in the PACU and need some assistance, either non-invasive or invasive. Probably many more that we are missing because they have subclinical symptoms such as swallowing problems. They don't really have anything PO in PACU, and they lately develop pneumonia a week later. It's very hard to find those associations. So why is residual neuromuscular blockade important? I'm going to talk only about 4 key studies, in my opinion, that give important lessons. This one was done over 20 years ago, but it's an excellent study. It was the first study done in Denmark that was prospectively randomized, blinded study looking at the residual muscle blockade and the clinical consequences in patients after surgery. You can see, maybe it's a little bit small, but you can see that about 700 patients were randomized to receive during surgery to a long-acting or 2 intermediate depolarizing neuromuscular blockade agents, and 3 different types of surgery in each group. They used usual care, qualitative 304 guided muscle blockade, and they reversed at the end of the case with neostigmine. So very usual, appropriate management at that time. And then in PACU, they monitored all patients with a quantitative 304 monitor. They defined residual blockade with a 304 less than 0.7. And this graph here, inside of this red rectangle, you can see, depending on the number of patients that had a 304 less than 0.7, here, this cutoff, and on the y-axis, the number of patients, depending on what muscle agent blockade agent they received. So you can graphically see that the patients that had received pancuronium were more with a residual, they had more residual blockade, more likely than the other 2 groups. And then these investigators followed the patients blindly and assessed the atelectasis and pneumonia up to day 6 using clinical and oxygenation criteria, and then an independent radiologist that was assessing the x-rays to confirm the diagnosis or not. So this table shows that the patients that had received pancuronium and had 4 times more higher percentage of postoperative pulmonary complications, again, atelectasis or pneumonia, within day 6, if they had received pancuronium or they had a 304 less than 0.7, compared to if they had appropriate muscle blockade reversal or if they had received other blockade agents that were not pancuronium. And these 3 graphs show the patients, the risk of postoperative pulmonary complications in patients divided by the type of surgery they received, the age on the x-axis, and whether they had received pancuronium or the other 2 intermediate relaxants. So you can see that the risk of postoperative pulmonary complications were higher with long-acting pancuronium blockers if they had received any residual muscle paralysis at the end of the surgery, older age, and abdominal surgery. This study is completely different. This is a database, big data type of study looking at the effect of receiving any neuromuscular blockade at all during general anesthesia with tracheal intubation in patients that had received an anesthetic in between 2006 and 10. So the first table that I'm going to show you plots the risk of these outcomes, desaturation, reintubation, and in-hospital death. And they had classified these patients to whether they had received any muscle paralysis or not after tracheal intubation, and the rate and the risk after adjusting and matching patients. So you can see that the risk was always increased in patients that had received any muscle paralysis during the surgery. This other table shows the secondary analysis, whether patients had any benefit, meaning a reduction of the risk for those complications, if they had been reversed at the end of surgery with neostigmine, again, we're before sugammadex, or they had any monitoring of the Trino-4 during the surgery. And surprisingly, these risks were not significantly reduced either by being reversed or by being monitored during surgery. Kind of surprising, right? So this same team by Eicherman did a very nice follow-up as a prospective validation of the effect of neostigmine because nobody really could believe the database findings. So what they did was observing around 3,000 patients, and you can see this table. I just highlighted the dose and the timing between neostigmine and the extubation to make sure that there was nothing inappropriate. Everything looks as you would expect. When they looked at the incidence of patients arriving at PACU with a train of 4 of less than 0.9, they were strikingly similar. So whether patients had received neostigmine at the end of the surgery or not, about 20% of them had some residual blockade. The oxygenation in PACU, meaning the SpO2 normalized by the FiO2 that patients were receiving in PACU, was also very similar. So neostigmine truly didn't seem to have any benefit in terms of preventing residual muscle weakness or improving oxygenation. They did some post-hoc analysis, and they showed in this table that patients that had received a greater than 60 mics per kilogram of neostigmine, or they had neostigmine that was somehow not supported by either the train of 4 reported measurement before tracheal extubation, or because there was no train of 4 monitoring at all during surgery, those patients had even higher risk than patients not receiving any reversal at the end of surgery at all. So it seems like the conclusion could be that neostigmine truly doesn't prevent residual muscle paralysis in about 1 out of 5 patients. And if you give a dose that is not supported, it's not appropriate, it may even increase the risk of that patient to have complications, or some complications at least. This publication came out in 2015, and it's a very nice multi-center observational study done in Canada. There was growing concern at that time with the residual muscle weakness in PACU. So they decided to do a multi-center observational study. They chose only abdominal surgery patients, and they used a quantitative train of 4 monitoring that was blinded to the anesthesia teams. And this is what they found. These are bars that are color-coded based on the train of 4 ratio, and the y-axis shows the incidence percentage of patients per bar. The 2 columns on the left are going to show the train of 4 measurement normalized to each patient's baseline at the beginning of the surgery before receiving any muscle paralysis, which is very nice, but it's not likely that we will have that. So I'm just going to focus on the 2 on the right, especially the measurement at the arrival at PACU. And you can see that only about 56% of patients had an appropriate train of 4 that was considered as 0.9 or greater, which means that 44% of patients had an inadequate reversal of the muscle paralysis. And I'm going to ask you to remember that 44%, because when this paper came out, we were testing the quantitative train of 4 monitor, the STEMPOT that we had at UCH. And Bart Williams was an AA student that was looking for a research project, so he decided to take this on. He observed 25 adults at UCH after general anesthesia with muscle paralysis, depolarizing blockade. And he took 2 or 3 measurements of train of 4 at the arrival to PACU, depending on the discrepancy between them. So this is what he found. Out of 25 patients, 9 had different degrees of inappropriate muscle paralysis reversal, meaning the train of 4 was only 0.5, 0.9 or greater. In these 16 patients, the darker you get in the pie, the worse residual muscle paralysis they had. So the incidence, even though it's a very limited number of patients, of course, it's very similar to what the multi-center Canadian study found. So this was happening. For this presentation, I went back and I was curious to see if there were any patients that had received a kidney transplant. And we had 3 in these 25 patients. And those are where they kind of fell in the train of 4. So why is residual neuromuscular blockade particularly concerning in patients with kidney dysfunction? Well, if you think about it, as we know, the residual blockade will put patients at risk of aspiration, hypoventilation, and later pneumonia. But what happens in patients with kidney dysfunction? All these additional risk factors that can put them at very similar complications after surgery. Whether they do not clear opioids and they get more sedation from them, more prolonged sedation from opioid sedatives, whether they have some encephalopathy or some autonomic dysfunction, whether they have immunosuppression for the kidney transplant and they are more prone to infection. The truth is that they have many additional risks for these same complications, and there is a limit to what we can do on the pathophysiology of kidney dysfunction, but we definitely can minimize the residual blockade in these patients. Now, I've been talking about monitoring of postoperative ventilation, and that's something that we do not have as part of a standard of care. So I'm going to spend a few minutes talking about it. This is a case report that was using this type of technology. It was published in 2016, and it's a 70-year-old female that arrives to PACU after a hip replacement. I'm showing you first the pulse oximetry strip that shows SATs around 100%. She's on 6 liters. You probably don't see, but she's on 6 liters per minute on face mask. Very stable SATs. She does have some desaturation or some drop in the saturation to 92%. She did not receive any opioids because she had no pain and improved spontaneously within 10 minutes. So they did a room air test, and only 20, 30 minutes later, she did have a hypoxemic event. She did fine, so that's not the story here. But I wanted you to think about that. If that happens in one of your patients, you would think she's perfectly fine, right? This is the monitor that they were using for that particular patient. And this is a monitor that tracks 3 points on the chest, and with a mathematical calculation, they estimate based on the age and the different parameters of the patient. You can use different formulas. They calculate the tidal volume and the predicted minute ventilation for that particular patient. So here, this monitor shows you the respiratory rate, the tidal volume. The product of them would be the minute ventilation that is being observed. Here you have the tracing. This is the minute ventilation that they are observing, and this is the predicted minute ventilation for that particular patient. So you can tell here, that shows the history of the breathing over a period of time, that she's been breathing. This is not this patient, but this patient has been breathing perfectly fine, a little hyperventilation, in fact. The band on yellow would show that the minute ventilation has been between 40 and 80% of your predicted minute ventilation. The orange would be that you're below 40%. So these are ways that you can change and track the hypoventilation episodes. These are the formulas for calculating the predicted minute ventilation on this particular patient that they used for this case report, and the threshold for hypoventilation that they used. And this is what the minute ventilation here shows for this particular patient, that even though she had 100% oxygenation, she had several, maybe a good 30-minute episode of hypoventilation. She recovered, and when they did the room air, she was hypoventilating again. It took, and this is the point why I'm showing you this parallel strip, it took 30 minutes for the patient from starting maintain hypoventilation to desaturate. And we all know that hypoxemia is a late sign of hypoventilation. So this technology just helps you objectivize that. I'm going to show you 3 brief examples of patients that have been done at UCH with this monitor. This was a 50-year-old after a kidney transplant that arrived to PACU, and you can see that the rhythm is regular, the respiratory rate is low, but regular. The tidal volume is appropriate. She's still hypoventilating, but this patient did fine. They just waited longer in PACU until she was very sleepy at the time, until she was had a very an improved cognition and breathing pattern. This was a patient that came to receive nursing-guided sedation for a colonoscopy to the GI lab. So this is a patient that, a gentleman that had the monitor placed in pre-op, then went to the suite, had 2 milligrams of Versed and 50 mics of fentanyl, and you can tell he was hyperventilating at that point, and he did not desat, but he hypoventilated after that sedation. And last, this was a 66-year-old gentleman that had a nail in the femur, arrived to PACU, had very high pain levels, but the PACU nurses were concerned with his known sleep apnea. So by showing that he was ventilating very appropriately, they were comfortable titrating opioids more often than not because of his OSA. So he benefited from the pain management. Then you may be thinking of, by now, hopefully you got the message that neostigmine was the only reversal agent that we had up until 2015. It's still not a very good reversal agent based on what we've seen in these manuscripts. But now we have sugammadex, right? So what's the big deal about it? We don't really know if things have changed that much. Definitely the information has definitely changed. The approach has changed. So lately, this is just why sugammadex was very novel at when it came out. Neostigmine, you all know, it's an anticholinesterase receptor antagonist, so it will help acetylcholine to stay longer and compete for the blockade agent for the nicotinic receptor. But sugammadex was very novel when it came out because it encapsulated the muscle relaxant, either rocuronium or recuronium, and it prevented it to be available for the receptor. So as I was saying, lately the focus has been mostly on comparing neostigmine and sugammadex. And last year, a Cochrane systemic review was published, and it has the best summary of these findings. So I'm going to show you 3 tables that show the comparison results. This table shows the results on looking specifically at the overall signs of residual muscle paralysis of any dose of any of those 2 drugs. And you can see the list of studies very consistently favor sugammadex, meaning that sugammadex is better preventing signs of residual muscle blockade after surgery. This looks at the time of the times that it takes from a T2 train of 4 of 2 twitches to a train of 4 of greater than 0.9 with specifically these 2 doses. And very consistent results, again, favoring Sugammadex. It's faster than neostigmine, reversing the muscle blockade. And this is looking at the adverse events of any dose of any of those two drugs. And I had to cut the table because it's long, so you can imagine it's being extensively studied. But again, it favors Sugammadex, meaning it has fewer adverse events than neostigmine when you focus on that particular aspect. So what's the problem with Sugammadex? It seems that it's better, it's faster, it has fewer adverse events. So what's the problem with kidney function? Well, it's almost exclusively eliminated, unchanged in the urine. So you can see here in this concentration of Sugammadex is in even in normal patients, it can take up to 48 hours to be completely eliminated, and it's still detected in the urine. And the concern in patients with poor kidney function is that because of the way it works by encapsulating the, let's say, rocuronium here, if it stays in the circulation, it can unbind. Because that would be the concern. If you can have late unbinding and late rocuronium increased levels, that could give you clinical weakness late in time. And just as a reference, a comparison, neostigmine is still eliminated in the urine by only 50%. So it's not a black or white, but it's definitely better in that way for patients with kidney dysfunction. So this is going to be a study that gave Sugammadex at that particular dose, a single IV injection, to patients that had, adult volunteers that had no surgery, no anesthesia. So I'm going to show you, because these two graphs are very nice. The graph on the left shows the almost linear correlation between the clearance of creatinine and the clearance of Sugammadex. So if you go from the brown to the light green and dark green, you have decreased kidney function, and you can also see a very progressively decreased clearance of Sugammadex. The graph on the right shows the levels of Sugammadex in plasma and how it clears over time in the same group of patients. So again, from brown to darker green, you have a longer detection of Sugammadex in plasma. And the problem with these patients in dark green dots are have severe kidney dysfunction, meaning a clearance of creatinine less than 30. And it can take 72 hours to still have detectable levels of Sugammadex in plasma. And we'll talk more about that time. This is a very similar study done in surgical patients, so no volunteers. And this was a study comparing the clearance of both Sugammadex on the left and rocuronium on the right from plasma in patients with normal kidney function, the dotted lines, and severe kidney dysfunction with solid lines. And you can see on the bottom graphs that normal patients can have still detectable but low levels of both Sugammadex and rocuronium around 6 hours to 18 hours, respectively. But in patients with severe kidney dysfunction, this goes for sure for 48 hours. And in some of these patients, it can take up to 7 days to have still detectable levels, which doesn't mean that those levels are sufficient to give problems or clinical problems. But still, this is the medication information approved by the FDA. So the Sugammadex has a warning on kidney dysfunction patients that explicitly says that no dosage is required, no dosage adjustment is required in patients with mild or moderate renal impairment, but it's not recommended to use Sugammadex in patients with severe kidney dysfunction with a clearance of creatinine less than 30, because of the potential prolonged exposure and the insufficient information of safety information. I'm going to show you the results of two studies. The first one is the most comprehensive, that looked specifically, was published in 2015 and looked specifically at the efficacy, safety, and pharmacokinetics of sugammadex in patients with severe kidney dysfunction. It's called the Firefly study. The graph on the left shows some of the comorbidities and the clearance of creatinine for both groups. Again, they compared controls with severe kidney dysfunction. They gave to all patients 4 milligrams of sugammadex at 1-2 post-tetanic twitches. And these are the times that took from the injection of sugammadex to achieve a train of 4 of 0.7, here 0.8, 0.9, and you can tell that everything was significant in terms of longer times for the achieving those train of 4 cutoffs in patients with severe kidney dysfunction by maybe 1 or 3 minutes, but still significantly different. They also, as I said, they looked at the pharmacokinetics, and they confirmed that patients with normal kidney function had cleared sugammadex in about 24 hours. Actually, I'm sorry, this is rocuronium levels. So all normal patients had clear rocuronium in 24 hours, but patients with kidney dysfunction still had variable levels of rocuronium at 48 hours. And some of these patients had levels that were still detected up to 7 days. When they looked at the adverse events, there were only 2 possible adverse events related to sugammadex. They were both in control patients with normal kidney function, which was surprising, and no adverse events in severe kidney dysfunction. And I want to just talk about this one in particular, because it was surprising for a patient with normal kidney function to have a recurrence of muscle blockade after sugammadex. And although the details in the manuscript were not clear enough in my mind, they thought that the administration of sugammadex had been too early to the last dose of muscle relaxant. So that's the way they justified it. But again, there were no adverse effects related to sugammadex in patients with severe kidney dysfunction. But having seen that you can still detect sugammadex and rocuronium up to 7 days, there is not enough safety experience to recommend the use of sugammadex in this patient population still. This is another study that was published around the same time. It was done in Brazil. Very similar results. I just want to show you this graph because it shows nicely that the variability is greater. The variability from the time from the administration of sugammadex to achieving the different train of 4 cutoffs that are shown here in severe kidney dysfunction is more variable than the times that it takes to reverse the blockade with sugammadex in normal patients. So meaning if you use sugammadex in patients with decreased kidney function, you may have to have more flexibility on the waiting period before you achieve the what you consider appropriate muscle paralysis reversal. Still, this study did not have any cases of any adverse events, any cases of recurrence in patients with severe kidney dysfunction once they achieved the train of 4 of 0.9. There were some concerns at the beginning of sugammadex coming out not being dialysable. So I'm just showing you this study done in a few ICU patients that required general anesthesia with muscle paralysis for procedures at the bedside. And they were reversed with sugammadex. They were already on dialysis, so they took samples of plasma from in and out of both sides of the filter, the dialysis filter. They were using high flux dialysis, And they found that Sugammadex is dialyzed by 70% on the first episode of the first cycle of high flux dialysis. So, and 50% on subsequent cycles. So that means that you reduce the starting levels by 70% and 50% later on. So meaning if you have a patient that you give Sugammadex and is going to need dialysis and you have concerns with the leftover Sugammadex effect or rocuronium leftover, you may need to contact the nephrologist or the dialysis unit to recommend the high flux dialysis. I was curious to see if I will admit my practice. Sometimes I do use rocuronium and Sugammadex in patients with receiving a kidney transplant, but I was curious to see what other people do. So this was blindly. I looked last week to the last couple months of kidney transplant patients. We had 50 included in this report, and 14 of them had received neostigmine, but the majority had received Sugammadex. I can tell you those are not all mine. So it seems like people are comfortable using Sugammadex in patients with severe kidney dysfunction, which I'm not going to go into whether it's good or bad, but you will see. The clinical options are basically, if you have a patient with mild or moderate kidney dysfunction, there's really not a big discussion. You can use Sugammadex, you can use the usual dose with the obvious clinical appropriate management. If you have a patient with severe kidney dysfunction, your options are whether to use a reversal agent that is the usual care, neostigmine, that we know that is not by any means perfect, reversing the muscle blockade, or use Sugammadex, but you're using it out of label because right now it's not recommended for patients with kidney dysfunction or severe kidney dysfunction. The last option that I thought of is to provide more safety data. So if you can provide more data showing that it's efficacious and it's safe, at some point the FDA may have better idea of how to guide the dosing or the administration of Sugammadex in patients with kidney dysfunction. So that's why we're going to be doing this study. It's going to be a double-blind, randomized, parallel study to compare the efficacy of Sugammadex versus neostigmine for the reversal of neuromuscular blockade at the end of kidney transplantation surgery in patients with severe kidney dysfunction. So very briefly, we're going to be enrolling 80 patients. They are going to be all adults receiving a kidney transplant surgery at UCH. And I'm not going to go into the exclusion criteria. Basically, we're going to consent them and randomize them to receive during surgery. And this is why you may see these patients coming to your operating rooms. We are going to randomize them to receive either rocuronium and reversal with neostigmine, or rocuronium as muscle relaxation and Sugammadex as reversal. And those two combination management is going to be guided by quantitative train of 4 monitoring. We're going to collect different times, and we're going to be dosing the Sugammadex or the neostigmine to a very strict dosing regimen. Once patients go to PACU, they're going to be receiving a quantitative train of 4 monitoring at different times and a continuous non-invasive minute ventilation monitoring that is going to be blinded for patient care because we don't want to interfere with the usual care. The main outcome is going to be the frequency of hypoventilation, but we have it this defined in a way that we will be adjusting for the train of 4 and also for the morphine equivalents that patients will be receiving. That way, if they hypoventilate because they are sedated or because they are receiving opioids, we will not assume that it's a residual blockade the culprit. So the hypothesis is that the intervention, meaning sugammadex group, will have a 50% or more reduction in the incidence of hypoventilation. And as I said, the primary outcome is focused on the PACU. We're going to be following them, though, to the floor. They're going to maintain the repeated quantitative train of 4 measurements and also have the continuous minute ventilation. And we're going to maintain it until either 3 days post-op or they are able to meet exclusion criteria or termination criteria, meaning they are free to ambulate and they are basically there is no concern that they have any residual muscle paralysis. We're also going to collect questionnaires that are subjective but validated, the PROMISE questionnaires on dyspnea. And we're going to look at pulmonary outcomes, kidney outcomes, hospital resources, and obviously safety. So all the adverse events are going to be reported. So in conclusion, inadequate neuromuscular blockade reversal is associated with increased risk of postoperative atelectasis and pneumonia. In patients with normal kidney function, the reversal with sugammadex compared to neostigmine results in overall fewer signs of residual muscle blockade, faster reversal, and reduced adverse events. The clearance of sugammadex is decreased in patients with severe kidney dysfunction, and the exposure to sugammadex can be prolonged to up to 7 days. There have been no reported adverse events on patients with severe kidney dysfunction that received sugammadex, but there is still insufficient information to recommend the use of sugammadex in patients with severe kidney dysfunction. And finally, I introduced you the study that will be starting soon, hopefully, comparing sugammadex and neostigmine in this patient population. And I wanted to thank Dr. Bartels for his support developing the protocol and assisting with the blinded assessments, Dr. Henthorn for agreeing to be our safety officer, Dr. Mandel and my colleagues from the transplant team for accepting to have these patients included in the study, and Colleen Dingman for helping with the protocol. And Dr. Adams and Spishak for accepting that these patients are going to be included in the study. Any questions, comments, concerns? Leslie.
I was wondering on the paper, and I can't remember which one it was, where they found such a prolonged tail on the rocuronium. Normal hepatic function, rocuronium should be metabolized. So are they hypothesizing that there is a release or a degradation of the sugammadex, so that's where the source of the rocuronium is, or we have no clue?
I don't know.
Or we should be worrying about aspects on rocuronium?
The question is, in this Firefly study, when they found rocuronium up to 7 days, measured in plasma of patients with severe kidney dysfunction, and why they explained that based on even though they have severe kidney dysfunction, they should have the liver metabolizing, and how they explained it. Actually, they didn't explain it. They just found it and they reported it. So I really don't know.
It just seems rather amazing.
Mm-hmm.
Because the only time you should really adjust your rocuronium dosing is with hepatic.
I don't know.
Maybe they're wrong. One of them. Is Catherine? I have a comment that's wrong, Catherine. It's not.
It's one study.
No, I mean, I just find it
Now, the levels, as I said, the levels, even if they are detectable, they may not do anything.
Yeah, but it still has to come from somewhere. If it's not detectable, we have to do it.
Yeah, I don't know.
Something's happening.
Any other questions? Any concerns with having Sugammadex used in a patient with kidney transplant that you're taking care of? I'm really curious to see that. Would any have any concern if you have a kidney transplant and we want to use Sugammadex in your patients? I will ask you before the case, but we need to.
That's only in adults, right? We do transplant.
It's only adults, yes. Yeah. Good. Well, that's it. You have time for coffee. Thank you for coming.